Hello, everybody. My name is Meg Fitzpatrick, and I am the psychology manager. And we're going to do a training on Criterion B. You'll notice that on many of these slides, they're quite wordy. I'll be talking through them, but I wanted you to have a place that you could go to reference these things should questions come up or you feel unsure about something. I wanted this to be a place that you could go to get the information that you're looking for without having to remember exactly what was said or how to describe it or any of those things. So let's jump right in. The first area in Criterion B is stereotyped or repetitive behavior. In the DSM, this is defined as stereotyped or repetitive motor movements, use of objects or speech, including simple motor stereotypies, lining up toys or flipping objects, echolalia, or idiosyncratic phrases. Obviously, this encompasses more than just that, and especially in adults, this is going to look quite different than it does in children. Things to keep in mind about this. Our clients may or may not have any clear stereotypies, and hand flapping and similar movements are much more common in people with higher support needs. Often, too, we need to be cautious about repetitive viewing of things, as this is something that's very common in Gen Z, especially in meme culture, in the audio culture of using the same sound for different things. It's very common for a lot of reasons, and we need to get specific and curious as to why those things might be happening. Listening for echolalia and repetitive use of phrases in the same tone can be super subtle, especially in adults who have learned to sort of hide that parts of themselves. This may include repeating you or repeating themselves. It's one thing for them to repeat you for clarification, and a different thing for you to say, all right, we're going to move on, and they say, move on. That's different and stand out. The nitty-gritty of this. Often, these repetitive behaviors are soothing and a form of self-regulation. This means that these behaviors are deliberate. Adults with autism often learn in childhood that these behaviors, like flapping or rocking, are not socially acceptable and therefore are trained out of them by caregivers. This is enormously important. If somebody comes in and says, as a child, I rocked all the time and my mom told me to stop, that's very, very notable. That's not something that we see a lot of kids doing, especially things like rocking, hand flapping, spinning, going up on toes, 2 paces and a spin. Those kinds of things are very important to flesh out. Asking clients about the things that they do that feel good that they would not do in public is also enormously important. There's, for many people, as I keep saying, especially adults, there's a fear of standing out. And for many people with these, as many people call them, stims, they choose not to do these things in public so that they are not seen as standout or weird or any of those kinds of things. In S2, in this section, the question that is asked is, one way to ask this is, if you did this movement in public, what might others think, or how would it look? And did you have these kinds of movements when you were younger? Asking clients what it's like to try to repress this behavior might also be really helpful. If they say, oh, it's really incredibly difficult for me, or I don't do it in public because it will stand out, so I don't do it with my hands, I do it with my feet, is also notable. Self-harm and headbanging or biting likely also falls into this category. Things like cutting or burning probably won't, unless it is repetitive in some way. When we start to differentiate these things out from other behaviors, it's important to get specific and understand the function of these behaviors. Repeating inside jokes and memes is not autistic. Repeating commercials, good till the last drop, what would you do for a Klondike bar? Out of context several times a day likely is. That's very different than, oh, very demure, very mindful. That's in the zeitgeist, right? Repeating things that just feel good is different. Leg bouncing, skin picking, fidgeting, knuckle popping, excoriation disorders, or other things done mindlessly may be more indicative of anxiety or ADHD or even just excoriation disorders and don't fall into this category. These repetitive behaviors are done with intention. And so separating out things like, oh, I bounce my leg when I'm sitting in a chair versus something like, I bounce my leg to the tune of When the Saints Come Marching In. And I do that every day when I sit at my desk, and that's calming for me. Those are two very different experiences of a very similar behavior. The same thing with knuckle popping. It's one thing to pop your hands or your wrists or whatever. It's different to pop them in sequence in the same way every time. There are a lot of commonplace behaviors that people do, especially people with anxiety, ADHD, depression, blah, blah, blah. But doing them in a highly specific or highly contextualized way is what we're really looking for. So getting really specific about it is important. A lot of clients may refer to these behaviors as tics, and determining their level of control is crucial. Tics are unconscious. Stereotopy has a feeling like relief or comfort attached. Tics, when we think about a true tic, it might be something like head knocking or jaw twitching. Those will be things people don't notice that they're doing, and that is not what we're looking for here. So takeaways in this section: autistic adults in studies have described stimming or stereotypic behaviors as primarily a self-regulatory mechanism that helps them soothe or communicate intense emotions or thoughts. This is not sensory seeking and is much more about general regulation. Are they repeating to get the same sensory experience, in which case it would go in the sensory things, or are they doing it in a particular way for a particular feeling of calmness, of settling, of anxiety? Studies on these behaviors also have shown that these behaviors are often not socially accepted. Things like fidget toys may be more acceptable replacements for larger, less accepted stims. So if you have a client that uses a lot of these toys, ask about their function. When did they start using it? What did it replace? We should ask about the symptoms, but if we have to do full-on detective work, it's not autism. If you need to really be getting into, oh, so you use a stress ball, when did that start? How old were you? That's very different than saying, I use a stress ball because I can't flap at work, and that feels like an okay replacement for me. Those are two very different experiences. The next area is adherence to routines or resistance to change. In the DSM, this is insistence on sameness, inflexible adherence to routines, or ritualized patterns of nonverbal behavior. So extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, needing to take the same route every day or eat the same food every day. Things to keep in mind about this: these are often multi-step routines, which are not related to OCD. Usually we don't count morning or bedtime routines unless they are extreme. And these behaviors really need to stand out in some way. And when we think about OCD, important to keep in mind and important to clarify with the client whether there is any fear or anxiety attached to these routines. If I do not do this, is something bad going to happen? That's very different than I need to do this or my day is ruined. People may have learned to manage these behavioral responses, especially adults, but then still hate change. Look for rigid rules or insistence on routines and upset with everyday changes. Ask questions like, what if your partner needs to take a shower before you do? Or what if you have to take a different bus route to work? Most people won't love these things. These are very common things for people to not enjoy, but it shouldn't then have a lasting impact on your day. Looking for detail, focus, and inability to pare down these routines are also essential parts of the information. Literal interpretation of language often goes in this category, especially if persons considered rigid in their understanding of language. For more subtle signs, this may be trouble with understanding language that isn't literal and concrete, asking a lot of questions, a lot of follow-up, needing you to explain yourself a lot of times, having trouble at work because they can't follow loosey-goosey kinds of instructions. The nitty-gritty of this is that these routines go beyond just a comfort into a way of life, that deviating from these routines in autistic adults may lead to intense feelings of upset that last beyond what may be expected. Everyone will have challenges with things like unexpected meetings at work. That's not a fun thing people look forward to, but having that ruin your day is standout. Clients with these behaviors likely view almost any interruption or change as negative, even if it's the inclusion of preferred activities. Even if their partner comes home and says, I got us tickets to Twilight, it's your favorite movie, you've seen it 10 times today, we're going to the local theater, surprise, that might be enough to precipitate a meltdown or intense emotions, even if it's preferred. Asking about how these changes in circumstances, if they are uncontrollable, what that feels like. If there's a plan to have a picnic at the park and then it rains, how might they then feel about that? Be specific about morning and nighttime routines if they are indoors. Are they beyond what may be expected? You know, getting up, taking a shower, brushing your teeth is pretty typical. But if there are things like surprising steps, I need to get up, brush my teeth, take a shower, and then sit for an hour in silence, and that cannot be deviated from, that stands out. Ask them what it's like for them when they travel. Do these changes in routine or lack of ability to follow the routines that they're used to, then throw a big wrench into their day or their experience or their mood. Asking about small routines are also important. Like, what do you do when you arrive at work? This may not be something that stands out to them, so they might not think to ask it. So being specific for them of, oh, when you get there, what is that like for you? Do you put your bag in the same place? Do you have to get your coffee from the same vending machine? Do you have to greet the same people in the same way each time? In terms of differentiating, routines that keep people on track, like med routines, is probably not enough. If I have to get my glass of water and put my meds next to it so that I remember to do it each day, that's just part of a healthy routine. Morning and bedtime routine, as I said, should be surprising in their intensity to meet this criteria. Routines that are preferred are different than routines that cause distress to deviate from. So it's one thing to say like, yeah, I have a routine and I like it. It's different to say I have a routine and if I deviate from it, I am upset for weeks. Be sure to include a ritual and routine in this category, not in stereotyped movements or behaviors. This is sometimes we see, oh, well, I have to follow the same thing each day can look stereotypic, but this would be the place for those kinds of things. And verbal rituals like saying the same thing in the same way to the same person at the same time each day goes into this as part of routine, not spontaneous repetition of words seen in stereotyped behaviors. If your child cannot get out of the car without you saying, good luck, don't get eaten by dinosaurs, I love you, as that is deviated from, that's a big problem for them. That goes here rather than repetitive words or phrases. Main takeaways, these routines and rituals must be life interfering to qualify, whether it's in their intensity or the challenges that come with interruption. For clients in the working world, as I mentioned, nobody likes surprise meetings, but if that then precipitates that they cannot attend or will not attend due to the level of distress that change causes, that may qualify. If they cannot or will not deviate from routines without preparation time, and even then having it be a struggle, that may qualify. If the change to routine causes changes to mood and behavior that last the rest of the day or week, that also may qualify. The next area is interests. In the DSM, this is described as highly restricted, fixated interests that are abnormal in their intensity or focus. For example, strong attachment to or preoccupation with unusual objects, excessively circumscribed, or perseverative interest. Things to keep in mind. Interest can be typical in subject, but the intensity is higher, especially in adults. Interests that can be used in both functional ways, like work and social, also go into this category. And these interests can be stable or change over time. It's okay if this is not something that they've been interested in since they were 7. The nitty-gritty. Not all clients with autism have special interests. So it's crucial to explore the difference between autistic special interests and things that are more like ADHD special interests, which we'll get into when we differentiate. Special interests are special because of their intensity. Questions to ask to get specific about this are things like, is this enjoyment getting in the way of life, work, relationships, responsibilities? Has their partner brought this up as a barrier in their relationship? Have they gotten in trouble at work for engaging in it there? Are their sleep cycles impacted by this? Learning and research can be special interests. Work can be a special interest. Some adult clients have found jobs related to their interests, so determining how long they've liked it and in what ways they pursue it will be helpful. For some of our clients, they have focuses on things like film, then they work in film, and their whole job is around film. So then when we ask this question, this doesn't always stand out to them as an interest because it's their job. So, even if it is something that may not seem like it stands out, as their work, maybe they're, a hairdresser, and then they tell you, oh, well, I've been interested in hair since I was a little kid. Getting into that can really help you sort of differentiate out what is just a job versus what is a special interest that's turned into a job. For example, a microbiology researcher who works 60 hours in office and then comes home and works more because they like it so much definitely stands out. A crocheter who will not cook, clean, or feed themselves because they are crocheting also stands out. Collections can be interests, how much money goes into it, how much time goes into it, is it a solo project or are others involved? Again, getting into those details around what those collections entail. And asking people what they were involved in as a child and how they pursued it then is also helpful, especially as adults learn that not everyone shares their level of enjoyment. They may not enjoy things in the same way now as they did when they were kids because they've learned that that is maybe not everybody's favorite thing to discuss, or they might be more reticent to share about what those experiences are like for them now, as they've learned that maybe not everybody cares to the same degree about snakes. In terms of differentiating this, collections may be a special interest, but remember, we're looking for things that stand out. People that collect family photos, keychains from their travels, that might not stand out. If they're collecting strangers' family photos because they just love family photos that much, it doesn't matter who's in them, it might. Of course, we're building an artistic leeway, so if that's part of their art processes, great. ADHD interests tend to be more brief and flighty, moving from interest to interest more quickly than others. The intensity might be there, but it's often much more short-lived. And, because the intensity may be also quite high, it's more the duration that we're looking for. So if it's every few months, we're moving on to something that's notable. And if it's something that we've lasted for years, also important to note. When you ask about this, look for monologuing or changes to mood or behavior when discussing these interests or collections. This will tell you a lot. However, keep in mind that high masking individuals may take some more prompting to get to this point, again, as they've learned. Takeaways: intense involvement in a topic or hobby that gets in the way of other things is something that we're looking for, or with standout in childhood in a very specific way is a good indication of a special interest. Last area in this is sensory responses. In the DSM-5, this is defined as hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. Apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, or visual fascination with lights or movement. Things to keep in mind: people will probably report a lot of sensory differences. We need to be differentiating out whether the sensory difference is unusual, like disliking the smell of peppermint is unusual, disliking the smell of garbage is not, and intense. Not trying to smell garbage but still taking it out is not intense. Disliking the smell of garbage and vomiting after is very intense. Many people with different neurodiversities or mental illness may be sensory sensitive. The nitty-gritty of this can, as we said, present as over or under sensitivity. Hypersensitivity, oversensitivity, is often to things like clothing textures, food textures, sounds, smells, visual input. Hyposensitivity are undersensitivity to things like bodily cues. Do they notice when they need to use the bathroom or when their body tells them that they're hungry? Do they respond in expected ways to things like pain, or do they not notice when they've been hurt? Check on their sensitivity to temperature and how they respond to being too hot or too cold, and if they notice. A big part of this is the emotional reaction. Do they become angry at unexpected sounds like someone coughing or construction in the distance? Things we might not think would be upsetting in the same way that someone jackhammering outside of your window, maybe. Check on their sensory seeking behaviors. Are they putting unexpected things in their mouth? Did they as a child? Do they smell things other people don't? Do they have to smell their desk every day before they start working? Those kinds of things stand out. How do these sensitivities show up in their day-to-day lives? Are they people that cannot function without loop earplugs or headphones with noise canceling? And this would go beyond someone that just doesn't want to hear the brakes of the train, but needs to have multiple layers of defense against that sound. What does sensory overload look like for them, and how do they deal with that after the fact is also going to be really helpful in differentiating out the levels to this. Many people have sensory sensitivity. Many people hate the sound of styrofoam. Lots of people don't like crowded places. Lots of people hate the sound of people chewing. Sensory sensitivity may be the most common challenge faced by the general public. So getting really specific about this and when this happens and what recovery looks like will be really helpful. The takeaways are what stands out, what makes this unique, what makes it autistic in its experience. How was it for them as a child? When people cannot grocery shop without headphones and a support person, and then they need to recover by being alone for hours in the dark, that stands out. If they hate repetitive clearing of the throat, maybe not so much. So, using your clinical judgment on this and figuring out, are they just someone that's sensitive to the environment that they have around them, or are they someone who really struggles to be in the environment, is something that we're looking for. As always, thank you for your time, attention, and hard work.